Imagine a magnificent racehorse, thundering down the track, every muscle straining. Then, suddenly, its performance just plummets.
Yeah.
It's struggling for air, not from an obvious injury, but because something really fundamental like oxygen delivery has gone awry.
It's a powerful illustration, isn't it? Shows how even these incredibly powerful animals are, well, vulnerable when basic physiology gets disrupted.
And that's exactly what we're diving into today. Welcome to the Deep Dives. We take complex topics, explore them thoroughly, and give you the shortcut to being genuinely well-informed. Our subject is equine hypoxemia, basically, a decreased amount of dissolved oxygen in the blood of horses.
Sounds technical, I know.
Yeah, it does sound technical, but understanding it is absolutely crucial. Crucial for appreciating a horse's overall health and, especially its athletic performance.
Right. So our mission today is to really unpack what hypoxemia is, clarify how it differs from related conditions like hypoxia.
Yeah. Good distinction.
Yeah, explore its maybe surprising range of causes, detail how vets diagnose it, the tools we use, and then look at the cutting-edge treatments available.
So by the end, you'll have a really solid grasp of this vital aspect of equine health.
It's at the goal.
Okay, let's break it down then. What exactly is hypoxemia? Because, like you hinted, it's more specific than just not enough oxygen, isn't it?
That's a vital distinction, absolutely. At its core, hypoxemia means a decreased amount of dissolved oxygen carried in the blood. For vets, we're looking at really specific measurements.
Okay, like numbers.
Exactly. We say a horse is hypoxemic when the arterial oxygen partial pressure, that's PaO2, drops below 80 millimeters of mercury.
80. Got it.
Or the venous oxygen partial pressure, PVO2, that's from the blood coming back to the lungs, is less than 40 millimeter Hg.
Right.
Or the overall oxygen saturation, SO2, or sometimes measured as SO2 with a pulse oximeter that falls below 95%.
95% saturation. So those are the thresholds.
Those are the precise thresholds we use professionally to define it, yes.
So, if hypoxemia is about oxygen in the blood, how is that different from hypoxia? I feel like I hear those terms used almost interchangeably sometimes.
They often are, and it's a really, really important distinction to make. Hypoxemia may cause hypoxia, but they're definitely not the same thing.
Okay.
Hypoxia is the broader term. It means decreased oxygen delivery to or utilization by the body's tissues.
Tissue level.
Tissue level, exactly.
Yeah.
And critically, cellular function starts getting badly affected when that PO2 we talked about falls below 60 millimilli Hg.
60. So blood oxygen levels are one thing, but actual tissue oxygen levels are another, and that's hypoxia.
You've got it.
Is it ever possible then for a horse to have, say, perfectly normal blood oxygen levels, but still be suffering from oxygen deprivation in the tissues?
That is a fantastic question, and it brings up a really key point, anemia.
Okay. Low red blood cells.
Right. Anemia means a low red blood cell count. Now, this reduces the overall oxygen-carrying capacity of the blood simply because there's less hemoglobin.
Less hemoglobin to carry the oxygen.
Exactly. But the dissolved oxygen, the PaO2, can still be perfectly normal. The blood plasma itself can be saturated.
Huh.
So you have enough oxygen dissolved, but there just aren't enough vehicles, enough red blood cells to actually deliver it efficiently to the tissues.
So that leads to hypoxia.
Yes, tissue hypoxia.
But not hypoxemia because the PO2 itself isn't low.
Precisely. It's a great example of how subtle these things can be, but how important the distinction is.
That makes sense. And if hypoxia does occur, it can affect, well, everything, all body systems.
Absolutely. Every single cell, every tissue, every organ needs oxygen. So if delivery or use is compromised, the impact can be systemic, devastating even.
Wow.
And we even categorize hypoxia based on where the problem starts. Atmospheric, tidal, alveolar, hemoglobic, different type.
And are certain horses more prone to this, like breed or age?
Not really by breed, age, or sex, no. Hypoxemia can affect any horse.
Okay.
But geographic location does play a role. At high altitudes, the amount of oxygen in the air you breathe in, the 5-IO2-2X, is lower.
Right, thinner air.
Thinner air. So naturally, the horse's PO2 and oxygen saturation will be a bit lower, just as a baseline. That's a factor.
Okay. So thinking as a horse owner then, what's maybe the one warning sign that often gets missed? Or maybe the most urgent symptom they should absolutely never ignore?
That's tough because there isn't one single always missed sign, as they're often tied to whatever the underlying problem is. But
Yeah.
perhaps one of the most urgent and noticeable is a sudden, significant drop in exercise performance. Or, maybe even more obviously, a clear struggle to breathe, even just standing still.
Okay, that makes sense. Performance drop or difficulty breathing.
Yeah. Owners might initially just notice general exercise intolerance. The horse just can't do what it used to. Or maybe more general signs like respiratory distress, a cough, or just being lethargic.
Less active?
Those sound like the subtle early warnings.
They often are. Yes.
And when a veterinarian comes in, what are they specifically looking for during the physical exam? What are those key indicators? Well, on physical exam, we're looking for several specific things. Tachypnea, that's rapid breathing, is a big one.
Okay.
As is tachycardia, a rapid heart rate. Coughing, obviously. You might see a reluctance to move, or this characteristic abducted elbows stance.
Elbows out.
Elbows held out, yeah. An outstretched neck, or a distinct nostril flare. All signs of increased effort to breathe.
Right. Trying to get more air in.
Exactly. And a fever can be present too, which might point towards an underlying infection.
And then there's that really striking, almost alarming sign, cyanosis, that bluish tinge. What's happening there?
Cyanosis, yeah, it's that bluish discoloration of the mucous membranes, gums, tongue.
Scary looking.
It is. And it develops when the PaO2 drops below 40 mmHg, or the oxygen saturation. 6 TO2 day gets down below about 75–80%. It's a critical sign, no question. Indicates profound hypoxemia.
So if you see blue, it's bad.
Very bad. However, and this is really crucial, the absence of cyanosis absolutely does not rule out significant hypoxemia.
Oh, okay. It's important.
Very important. Cyanosis is often a late and severe sign. A horse can be in serious oxygen trouble well before showing any blue tinge.
Got it. Don't wait for blue. Beyond cyanosis, what other respiratory or even systemic signs might point towards hypoxemia?
We also look for dyspnea, just general difficulty breathing, and increased respiratory effort. That might be mostly on inspiration or expiration, or kind of mixed. An abdominal press, where they're using their stomach muscles to push air out, or actual open mouth breathing. Those are very ominous signs.
Definitely not normal for a horse.
Not at all. And beyond the respiratory system, cardiovascular signs matter. Pale mucous membranes, a prolonged capillary refill time, when you press the gum and see how fast the color returns, weak peripheral pulses.
Right.
Neurological signs, too, because the brain needs oxygen. Cerebral hypoxia can cause ataxia, wobbliness, weakness, depression, anxiety, even seizures or collapse.
Wow.
Sweating, poor exercise performance. Those can also be indicators.
So quite a range of signs. Okay, we know what it is and how to spot it. Now, the big question, the why. What are the fundamental mechanisms that actually cause a horse to become hypoxemic?
Right. This is where it gets really interesting, physiologically speaking. There are essentially 5 core mechanisms, and importantly, often more than one is happening at the same time.
5 mechanisms, okay.
The first one is hypoventilation. Simply put, this means decreased alveolar ventilation. The horse isn't breathing effectively enough.
Not moving enough air in and out of the deep lungs.
Exactly. And this leads to increased carbon dioxide in the blood. We call that hypercapnia. Measure it as increased PaCO2 ascent. And that buildup of CO2 directly causes a decrease in the pepaukenton, the oxygen level.
Okay, so hypoventilation is number 1. What causes that decreased breathing?
Various things. Central nervous system depression is a big one thing. Anesthesia or head trauma.
Right.
Neuromuscular diseases that affect the breathing muscles. Severe airway obstruction, obviously, or problems with the thoracic wall itself, like significant trauma.
Makes sense.
And it's worth noting, a low PaO2, like below 60, normally stimulates respiration. It's a trigger to breathe more.
Sure.
But in hypoventilation, just breathing faster often doesn't fix the oxygen level much because oxygen doesn't diffuse across into the blood nearly as easily or quickly as CO2 diffuses out.
Oh, okay. So hypoventilation is one clear pathway. What about the more common scenarios? You mentioned this is often complex in horses. What's the next major mechanism?
The next one, and arguably the most common cause we encounter in horses, is something called ventilation-perfusion mismatch, or VQ mismatch.
VQ mismatch.
Imagine the lungs as this incredibly complex system of air sacs, the alveoli, and tiny blood vessels, the capillaries. For efficient gas exchange, the air coming in the ventilation, V needs to match up with the blood flow going past the perfusion.
Right, air meets blood.
Exactly. VQ mismatch happens when they don't match up properly. You get areas of the lung that are poorly ventilated but still getting good blood flow. That's a low VQ unit.
So air can't get in, but blood's still flowing past? Like a blockage.
Sort of, yeah. Causes of low VQ include things like bronchoconstriction, mucus plugging, pneumonia, where the air sacs are filled with gunk, pulmonary edema.
Fluid in the lungs.
Fluid in the lungs, yes. And a really common one is atelectasis lung collapse. We see this frequently in horses that are down, recumbent, or under anesthesia because the weight of their abdominal organs compresses parts of the lung.
Ah, Okay, so that's low VQ. What about the other way around?
The other way is high VQ. That's where you have good ventilation, air is getting in fine, but poor perfusion, not enough blood flow. We sometimes call this dead space ventilation because the air isn't participating effectively in gas exchange.
Like the air hits a dead end because there's no blood vessel there.
Pretty much. Causes here include things like a pulmonary embolism, a blood clot in the lung artery, or severe emphysema, where the lung structure is damaged.
Okay, so VQ mismatch is number 2, and very common. What's the third mechanism?
The third is shunt. You can think of a shunt as the most extreme form of VQ mismatch.
Extreme mismatch. How so?
It's where blood flows through parts of the pulmonary circulation that are completely non-ventilated. It entirely bypasses any area where gas exchange could happen.
So the blood goes through the lungs, but picks up zero oxygen.
Exactly. And the really crucial point about a shunt is that the resulting hypoxemia is often refractory to giving 100% oxygen.
Meaning giving extra oxygen doesn't help.
Doesn't help much, or at all, because that shunted blood literally never comes into contact with the oxygen you're providing in the airways.
That makes sense. What causes that kind of complete bypass?
Causes include severe atelectasis, large areas of lung consolidation like you see in severe pneumonia or lung abscesses, significant pulmonary edema, and also certain cardiac defects, right to left cardiac shunts, where blood bypasses the lungs entirely through a hole in the heart.
Okay, shunt is number 3, and tough to treat with oxygen. What about number 4?
Number 4 is diffusion impairment. This is about the barrier itself, the thin membrane between the alveoli, air sacs, and the capillaries, blood vessels.
The place where oxygen actually crosses over.
Precisely. If this alveolar capillary membrane becomes thickened, for instance due to inflammation or scarring, it hinders the ability of oxygen to diffuse across efficiently.
So the oxygen's there, the blood's there, but the transfer is slow or blocked.
Exactly. This is less common as the sole cause of really severe hypoxemia, but it definitely contributes in conditions like interstitial lung disease, think severe equine asthma, or pulmonary fibrosis where there's scarring.
Okay. And the last one, number 5.
The fifth mechanism is simply a reduced inspired oxygen fraction, or 5022.
Meaning not enough oxygen in the air they're breathing in the first place.
Just that. As we mentioned, high altitude is one example. In clinical practice, though, it's pretty rare unless there's, say, a malfunction with an anesthetic machine delivering the gas mixture.
Right, so those are the 5 core ways it happens. Hypoventilation, VQ mismatch, shunt, diffusion impairment, and low 552 tool.
Correct. And often, especially with lung disease, you'll have elements of VQ mismatch, maybe some shunt, maybe some diffusion impairment, all contributing.
Complex picture. Okay, let's talk specific diseases then. What conditions commonly fall under these mechanisms and lead to hypoxemia in horses, starting with the respiratory system itself?
Sure. Within the respiratory system, upper airway obstructions are pretty common culprits. Things like laryngeal hemiplegia, what people often call roaring.
Yeah, heard of that.
Dorsal displacement of the soft palate, or DDSP, epiglottic entrapment, issues in the nasopharynx or guttural pouch diseases like empyema, which is pus collection.
So blockages up high?
Exactly. Tracheal collapse or stenosis or even masses or tumors up there can cause obstruction too.
Okay. And then lower down, lower airway diseases.
Oh, yes. Lower airway diseases are huge contributors. Equine asthma is a major one, that spectrum, that includes what we used to call HEAVs or recurrent airway obstruction, RAO, and inflammatory airway disease.
Got it.
Various types of pneumonia are big players. Bacterial, viral, like equine herpes virus or influenza, fungal, even parasitic, like lungworms in some areas.
Pneumonia, yeah.
Then there's pleural pneumonia, often called shipping fever, where you get infection and fluid in the pleural space around the lungs. That can be really severe.
Shipping fever, in fact.
Pulmonary edema fluid in the lungs, either from heart problems, cardiogenic or non-cardiogenic causes like acute respiratory distress syndrome, ARDS, or severe sepsis.
Right.
Exercise-induced pulmonary hemorrhage, EIPH, or bleeding. Pulmonary fibrosis, scarring. Pulmonary embolism, clots. And sometimes, unfortunately, neoplasia or cancer in the lungs.
Wow, that's a lot of lung-specific issues.
Yeah.
What about structural problems, like the chest wall or the diaphragm?
Yes. Those definitely impact breathing and oxygenation. Conditions like pneumothorax air getting into the pleural space and collapsing the lung.
Collapsed lung.
Or pleural effusion, excess fluid building up in that same space, squeezing the lungs. Diaphragmatic hernia, where abdominal organs push through the diaphragm into the chest cavity.
Oh, wow.
And significant trauma like multiple rib fractures, or what's called a flail chest, where a segment of the chest wall moves paradoxically. All of these impair the mechanics of breathing.
It's so clear how central the respiratory system is. But you mentioned earlier, there can be non-respiratory causes too, systemic issues leading to hypoxemia.
Absolutely. Now remember our distinction. Anemia causes hypoxia, low tissue oxygen, but typically doesn't directly cause hypoxemia. POT2 might be normal, though it massively impacts overall oxygen delivery.
Right, important clarification.
But other systemic things can contribute to hypoxemia: circulatory shock, where perfusion is poor, severe cardiac disease, though interestingly, it's rarely the primary cause of severe hypoxemia in horses compared to lung disease.
Huh.
Severe metabolic acidosis can affect things. Certain toxicities are important. Methemoglobinemia from things like red maple leaf toxicity changes the hemoglobin so it can't carry oxygen effectively. Carbon monoxide poisoning is another.
Toxins, right.
And a huge one, especially in hospital settings, is general anesthesia. It's a major cause of hypoxemia during and after procedures, mainly due to that atelectasis, lung collapse, and VQ mismatch we discuss.
Anesthesia itself is a risk factor.
A very significant one. And finally, sepsis, or systemic inflammatory response syndrome, ERNS. That massive body-wide inflammation can lead to diffuse lung injury, like ARDS, causing severe hypoxemia.
That's a really comprehensive list of causes. Are there specific risk factors, then, that make a horse more likely to end up in one of these situations?
Yes, definitely. We've touched on some. General anesthesia is a big one.
Clearly.
Foals born from mares that had dystocia, a difficult birth, are at risk of perinatal asphyxia, oxygen deprivation around birth.
Okay, foals.
Foals on farms where the bacteria Rhodococcus sequia is endemic are at higher risk of developing that specific severe pneumonia.
Equines.
Young performance horses, especially those trailered long distances, seem more prone to developing pleuropneumonia, that shipping fever.
Travel stress.
Seems to be a factor. Infection with equine herpes virus 5 has been linked to a specific condition called equine multinodular pulmonary fibrosis, EMPF, which involves lung scarring.
Herpes virus 5. Interesting.
And for horses prone to severe equine asthma, environmental factors are key triggers, particularly dust and mold in hay or bedding.
The environment matters hugely for asthma. So a vet suspects hypoxemia based on the signs, the history, the risk factors. How do they definitively diagnose it? You mentioned measurements. What's the gold standard test?
The absolute gold standard for documenting hypoxemia is arterial blood gas analysis, or ABG.
ABG? Okay.
This test directly measures the partial pressure of oxygen dissolved in the arterial blood, that PO2O2 we keep talking about, and also the arterial oxygen saturation, SaWa2, which is how much oxygen the hemoglobin is carrying.
And you gave the numbers earlier. Normal PO2, usually over 90 at sea level. Hypoxemia generally under 80, severe under 60.
Exactly those numbers.
Does the ABG also help figure out why the horse is hypoxemic? Does it point towards one of those 5 mechanisms?
It absolutely does, and that's why it's so incredibly valuable. The key is looking at the arterial carbon dioxide level, the PaO2 at the same time.
Okay, CO2 is the clue.
It's a major clue. If you have hypoxemia low, PaO2, and hypercapnia high, PaO2, say above 45 mmHg, that points directly to hypoventilation as the cause, or at least a major component.
Low oxygen, high CO2 means not breathing enough. Simple.
Pretty much. But if you have hypoxemia, low PaO2 with normal capnia, normal PaO2, or even hypocapnia, low PaO2, often because the horse is hyperventilating trying to compensate.
Right. Breathing fast, but still low oxygen.
Then you're looking much more towards VQ, mismatch, shunt, or diffusion impairment as the primary problem. The CO2 level helps differentiate those mechanisms.
That's really useful. I also saw something mentioned called the alveolar arterial oxygen gradient, the A gradient. What's that? How does that help?
Yes, the AA gradient. It's a calculated value, basically the difference between the theoretical oxygen level in the alveoli, the PaO2, which we estimate, and the actual measured oxygen level in the arterial blood.
Okay, the difference between what should be there and what is there.
In simple terms, yes. A normal A gradient for a horse is pretty small, typically 5 to 15 mmHg. If you find a normal A gradient but the PaO2 is high, that confirms hypoventilation is the main issue.
Matches the CO2 finding.
Right. But if the A gradient is increased, meaning a bigger difference than expected, especially if the PaO2 is normal or low, that strongly points towards VQ mismatch, shunt, or diffusion impairment. It tells us there's a problem with oxygen transfer across the lung itself.
So it really helps pinpoint where the breakdown in oxygenation is happening.
Exactly. It adds another layer to interpreting the ABG results.
Getting that ABG sample absolutely right sounds critical then for accuracy. Can small mistakes really throw off the results?
Oh, absolutely. Precision is paramount.
Yeah.
You need heparinized blood collected anaerobically, meaning no air bubbles get in the syringe.
No air. Got it.
It needs to be capped immediately with a rubber stopper, ideally analyzed within 15 to 20 minutes.
That's fast.
It is. Now, if you use specific syringes that contain powder heparin, not liquid, and immediately put the sample on ice, you can usually get valid results for up to maybe 3 or 4 hours.
Okay. Icing helps by time.
It does, but you have to be careful. Any exposure to room air before capping, using too much liquid heparin, which dilutes the sample, using standard plastic syringes, which can be slightly gas permeable, delaying analysis too long, or not chilling it properly, all of these can significantly skew the results, give you false readings.
Wow. Lots of pitfalls.
There are. The good news, though, is that these samples are generally valid if run on standard human blood gas analyzers, which means many clinics and hospitals can process them quickly, even in emergencies.
That's handy. Okay. Beyond the gold standard ABG, what other lab tests or diagnostic tools do you use?
Well, we can measure blood lactate levels, often with a convenient handheld analyzer right there stall side. High lactate hyperlactatemia is consistent with hypoxia, poor tissue oxygenation.
Lactate indicates tissue problems.
Yes. A standard complete blood count, CBC, and a biochemistry panel are also crucial. They help evaluate for systemic inflammation, infection, anemia, and check on organ function like kidneys and liver.
General health picture. Makes sense. What about imaging? Seeing inside.
Imaging is essential. Radiography, X-rays, and ultrasonography are the mainstays for evaluating the heart and lungs.
X-rays and ultrasound.
Thoracic radiography, chest X-rays are great for looking at the lung tissue itself, the pleural space, the mediastinum, the heart silhouette. They can identify pneumonia, pulmonary edema, pleural effusion, pneumothorax, sometimes masses.
But tricky in big horses sometimes.
Can be challenging to get really good deep views in very large horses. Yes, limitations exist. Thoracic ultrasound, on the other hand, is excellent for looking at the surface of the lungs, the pleural space, and the diaphragm. It's fantastic for identifying effusions, areas of lung consolidation right up against the chest wall, contusions, or atelectasis.
So they complement each other.
Very much so. Ultrasound is particularly good for guiding procedures like draining fluid from the chest.
And for more complex cases, or things deep inside.
For more complex situations, we might turn to advanced imaging. Computed tomography, CT scan, gives incredibly detailed cross-sectional images. It's great for complex lung disease, deep lesions, or if we suspect bone involvement, like with rib fractures. The downside is it requires general anesthesia.
Ah, right. Anesthesia risk again.
Always a consideration. Nuclear scintigraphy, using radioactive tracers, can sometimes help detect very subtle pulmonary pathology, like early inflammatory changes or perfusion defects. And cardiac ultrasound, echocardiography, is vital if we suspect primary heart disease is contributing.
Echo for the heart. Got it. What about less invasive tools? Maybe things you can use for continuous monitoring or quick field tests?
Definitely. Pulse oximetry, measuring SpO2 is a really common one. It's non-invasive, gives a continuous reading of oxygen saturation.
Little clip thing.
Yeah, often a probe placed on the tongue in an anesthetized horse, or sometimes a special nasal probe for conscious horses. It's very useful for trend monitoring, seeing if things are getting better or worse.
But not as accurate as ABG.
Not as accurate, especially when saturations get low, say below 90%. And it can be unreliable if there's poor blood flow to where the probe is, or if the horse is moving a lot, but still a valuable tool.
Okay. What?
Capnography measures end-tidal CO2 at SpO2, that's the CO2 level at the end of an exhaled breath. It gives a non-invasive estimate of the arterial PaCO2, so it helps monitor ventilation.
Monitoring breathing effectiveness.
Yes. There's also a simple rebreathing bag test. You hold a bag over the horse's muzzle briefly, making them rebreathe their exhaled air. It stresses their respiratory system slightly, and how they respond can give a quick field assessment of their respiratory reserve.
Interesting field test.
And of course, never underestimate a thorough clinical examination. Detail auscultation, listening carefully to the lungs with a stethoscope for crackles, wheezes, or areas where lung sounds are diminished. Percussion, tapping the chest wall, checking for nasal discharge, cough quality, palpating the trachea, all fundamental.
The basics still matter.
And
for actually looking inside the airways.
for that, we use endoscopy. Passing a flexible camera scope up the nose allows direct visualization of the upper airway, larynx, pharynx, guttural pouches to diagnose obstructions like roaring or DDSP, or assess tracheal collapse or inflammation, mucus accumulation.
Seeing the problem directly.
Exactly. And dynamic endoscopy, where the scope is used while the horse is exercising on a treadmill or track, is crucial for diagnosing conditions that only appear during high-intensity work.
Like the palate flipping up during exercise.
Precisely. And if we need samples from the lower airways to figure out what kind of inflammation or infection is present, we perform either a tracheal wash, TW, or a bronchoalveolar lavage, BAL.
Washing out samples.
Essentially, yes. We instill sterile saline and then suction it back out, collecting cells and fluid for cytology, looking at the cells under a microscope, and for bacterial or fungal cultures. This helps differentiate inflammatory conditions like asthma from infectious pneumonia or even neoplastic disease.
Okay, that's a whole toolkit for diagnosis. So we've identified hypoxemia. We've maybe figured out the likely cause. Now, the really big question, treatment. What's the absolute primary goal when you have a horse struggling with low oxygen?
The single most important aspect of treatment, without a doubt, is resolution of the primary cause of the hypoxemia.
Fix the underlying problem.
That is paramount. While we absolutely provide supportive care, sometimes intensive supportive care, ultimately, fixing the root cause, the pneumonia, the airway obstruction, the heart failure, is what allows for recovery.
Makes sense. But in an emergency, while you're still figuring out that primary cause or starting treatment for it, what steps do you take immediately to stabilize the horse and just get those oxygen levels up?
Right. Emergency stabilization is critical. First step is ensuring a patent airway. That might involve suctioning out secretions, removing any obvious foreign bodies. In cases of severe upper airway obstruction, sometimes an emergency tracheostomy, creating a temporary opening into the trachea and the neck, is life-saving.
Bypassing the upper blockage.
Exactly. Then, oxygen supplementation is usually the next key step. Giving oxygen therapy via nasal insufflation, just running a tube into the nostril, can be very effective at raising the PO2.
Nasal oxygen, how much do you give?
We typically aim to limit the inspired oxygen concentration to around 30–45% with standard nasal cannulas. Higher levels, maybe up to 60%, can sometimes be achieved with direct tracheal insufflation via a tracheostomy tube if one is placed.
Are there specific things to watch out for with oxygen therapy? Any risks?
Yes, a couple crucial ones. First, the inspired oxygen must be humidified. Dry oxygen gas is very irritating and damaging to the delicate mucous membranes of the airway.
Humidify, how?
Usually by bubbling the oxygen through a container of sterile water before it goes to the horse. Simple but vital.
Okay. What about flow rates?
Typical starting flow rates are around 3 to 5 liters per minute for foals and maybe 5 to 10 liters per minute for adult horses, sometimes higher depending on the severity and response.
Got it. Any other risks besides drying?
Yes, oxygen toxicity is a concern if high concentrations, say over 50% 5022, are maintained for prolonged periods, like more than 12 to 24 hours. It can actually damage lung tissue. Or if the PO2 gets driven too high, say consistently above 100 mmol OGG.
Too much of a good thing.
Can be. Also, a more subtle risk. If the horse's main drive to breathe was actually the low oxygen level, the hypoxic drive, suddenly giving lots of oxygen can potentially decrease their respiratory drive and actually worsen hypoventilation, making the CO2 climb.
Or a tricky balance.
It can be. And remember, as we discussed with shunts, oxygen therapy is not particularly helpful in cases of significant right-to-left cardiac shunt, persistent fetal circulation in foals, or severe VQ mismatch that acts like a large shunt. The blood just isn't seeing the oxygen.
Right, the refractory cases. So what if nasal oxygen isn't enough? Or if the main problem really is severe hypoventilation, that high CO2.
In those more severe situations, mechanical ventilation becomes necessary, putting the horse on a ventilator.
Like in human ICUs.
Exactly the same principle. This is indicated for severe, persistent hypoventilation, say, PACO-22 consistently staying above 65 mmol Hg despite other measures, and also for severe hypoxemia that isn't responding to oxygen therapy alone.
Is that feasible in horses?
It's definitely feasible, especially in foals, and also commonly used in anesthetized adult horses during surgery. Ventilating a conscious adult horse is much more challenging and usually requires heavy sedation or anesthesia.
But possible in foals.
Yes. Conscious foals can often be intubated nasotrachely, a tube down the nose into the windpipe, and managed on a ventilator, sometimes with sedation. We generally prefer assisted ventilation modes where the ventilator supports the foal's own breaths rather than fully controlled ventilation.
Just supporting, not taking over completely.
Ideally, yes. And maintaining that airway is crucial. Periodic suctioning of the endotracheal tube is necessary to prevent mucus plugs. After they're weaned off the ventilator, temporary nasal oxygen is often still recommended for foals.
Are there advanced ventilator settings used?
Yes, techniques like positive end expiratory pressure, or PEEP, are often used. PEEP applies a small amount of pressure at the end of exhalation to help keep the small airways and alveoli open, preventing collapse.
Fighting that atelectasis.
Exactly. And sometimes specific recruitment maneuvers, temporary high-pressure breaths, are used to try and pop open collapsed lung units. It's all about improving that VQ matching.
Makes sense. Beyond just breathing support, what other supportive care is vital for these critical horses?
Fluid therapy is a big one. Careful fluid administration is needed to correct dehydration and maintain good circulation and perfusion. However, you have to be really cautious to avoid fluid overload.
Too much fluid is bad.
Can be very bad, especially in neonates, horses with underlying heart conditions, or those with kidney failure. Overhydration can worsen pulmonary edema or strain the heart. It's a fine balance.
Balance again.
Always. Other supportive care includes maintaining normal body temperature, normothemia, providing adequate pain management, and ensuring nutritional support, especially for horses that are critically ill for more than a day or two.
The whole picture matters. Okay, so that's the immediate stabilization. What about specific treatments once you have a better handle on the underlying cause?
Right, that's when treatment becomes highly tailored to the diagnosis.
Examples.
Sure. If it's bacterial pneumonia, appropriate antibiotics are critical. For equine asthma, bronchodilators, drugs that open the airways, like inhaled albuterol or oral clenbuterol, are key, often combined with corticosteroids to reduce inflammation.
Asthma meds. Okay.
If there's thick mucus, mucolytics like nebulized N-acetylcysteine can help thin it out. For pulmonary edema, diuretics like furosemide Lasix are used to pull fluid off the lungs.
Diuretics for fluid.
N-ascarides, non-steroidal anti-inflammatories like flunixin, meglumine, banamine, are often used to reduce inflammation and pain associated with respiratory disease or surgery. And in some cases, like certain upper airway obstructions or severe chest trauma, surgical intervention is necessary.
Surgery might be needed. What about treating hypoxemia specifically related to anesthesia? You said that was common.
Yes, for anesthesia-related hypoxemia, management involves techniques often used during the anesthesia itself. Intermittent positive pressure ventilation, IPPV, basically ventilator support using PEEP, maybe recruitment maneuvers. Careful positioning is important after anesthesia too, like keeping the horse in sternal recumbency up on its chest as long as possible during recovery helps the lungs reinflate.
Positioning matters.
Definitely. Continuous monitoring during and after anesthesia and optimizing the anesthetic drugs and techniques used are all part of preventing and treating it.
And for those systemic issues, like shock or sepsis?
For systemic problems, treatment targets that issue. Severe anemia might require blood transfusions. Circulatory shock needs aggressive fluid resuscitation, sometimes with vasopressors or inotropes drugs to support blood pressure and heart function. Sepsis, or SIRS, requires appropriate antimicrobials and intensive organ support.
It sounds like incredibly intense, detailed management, especially for ventilated patients. What's often the biggest practical challenge you face in the field, or even in hospital, when trying to stabilize a horse with really severe hypoxemia? Is it equipment, time, owner cooperation?
That's a great question. Often in the most severe cases, it's a combination of the sheer critical nature of the patient and the limited time you have to intervene effectively. Getting a definitive diagnosis rapidly while simultaneously providing life support is a huge challenge.
The clock is ticking.
Absolutely. And outside of a dedicated referral hospital, access to things like immediate ABG analysis, mechanical ventilators, advanced imaging, and 247 intensive care staffing can certainly be a limiting factor in some situations. Cost can also be a significant factor for owners facing intensive care needs.
Real-world limitations.
Yeah.
That makes perfect sense. Any crucial safety precautions when dealing with all this, especially oxygen?
Oh, definitely. Safety is paramount. Number one, absolutely no combustible materials, no oil, grease, and absolutely no smoking anywhere near oxygen tanks or delivery systems. Oxygen greatly accelerates fire.
Fire risk.
Oxygen tanks must be securely chained or strapped to an immovable object like a wall or a sturdy heart. If a tank falls over and the valve breaks off, it can become a dangerous projectile.
Wow. Okay, secure the tanks.
Always wear safety glasses when handling tanks and regulators. Keep your face away from the valve opening when turning it on. And when dealing with endotracheal tubes or tracheostomy tubes, aseptic technique is vital to prevent introducing infection directly into the lungs. and, as mentioned, careful fluid therapy to avoid overload.
Good reminders.
Mm.
Are there any treatments that are actually contraindicated, things you should avoid in specific hypoxemia scenarios?
Yes, a couple come to mind. The respiratory stimulant drug doxapram should generally not be used just to try and improve respiratory function in otherwise healthy anesthetized patients, especially during weaning from anesthesia. Its effects are very temporary, and it can sometimes cause paradoxical apnea or stop breathing.
Okay, avoid doxapram routinely.
Right. And another specific example. While ventilation can be life-saving, using mechanical ventilation aggressively in foals with severe meconium aspiration syndrome needs caution. The meconium can block small airways, and forcing air might risk overdistending and damaging other parts of the lung, causing barotrauma.
Nuances, even with ventilation. Okay, so treatment is underway. Maybe the horse is stabilizing. How do you monitor their progress? How do you know when it's safe to reduce support, like oxygen?
Monitoring is continuous. Serial arterial blood gas evaluations remain the gold standard to track PPO2s and PACO2, so oximetry is used for continuous trend monitoring between ABGs.
Keep checking the numbers.
Exactly. As the PO2 improves on a certain level of oxygen support, we gradually decrease the FATO2, PO2 oxygen fraction. We attempt periodic trials where we turn the oxygen off completely and see how they do breathing room air, monitoring their PO2 or 6-PO2, and just as importantly, their clinical signs, their respiratory rate, effort, and overall demeanor.
Watching the horse, not just the monitor.
Absolutely critical. We typically aim to discontinue oxygen therapy when the horse can consistently maintain a PO2 greater than 70 millimole Hg, maybe slightly lower, like above 60, in premature foals while breathing room air, and they look comfortable doing so.
Makes sense. What about the overall prognosis? You've listed so many causes. Is it generally good, bad, or just highly variable?
It is highly variable. Prognosis depends almost entirely on the specific underlying cause, the severity and duration of the hypoxemia before effective treatment began, and of course the individual horse's response to that treatment.
Depends on the cause.
Very much so. Acute, really severe conditions like aggressive pleural pneumonia, ARDS, or major anesthesia complications. Unfortunately, those often carry a guarded to poor prognosis. The lung damage can be too extensive.
Some are really tough.
They are. On the other hand, something like mild hypoxemia due to moderate asthma that responds well to medication might have a good prognosis for life, although maybe not for top-level athletic performance. Chronic hypoxemia, like from severe, poorly controlled asthma, can certainly lead to reduced performance and quality of life long-term.
So it really runs the gamut. And what are the potential complications from having endured hypoxemia, even if the horse survives the initial crisis and the primary cause is treated? Can there be lasting damage?
Yes, unfortunately, significant hypoxemia, especially if prolonged, can lead to serious complications. Brain damage is a major concern.
From lack of oxygen to the brain.
Exactly. Cerebral hypoxia can lead to lasting neurological deficits, altered consciousness, persistent blindness, seizures. Cardiac arrhythmias, irregular heartbeats can occur due to hypoxemic damage to the heart muscle itself.
Heart damage, too.
Then there's multi-organ dysfunction syndrome, MODS, where sustained tissue hypoxia starts to affect multiple organ systems. The brain, kidneys, liver, gastrointestinal tract, they can start to fail.
Domino effect.
It can be. Cardiac arrest is, of course, the ultimate severe outcome. Laminitis is a very common and potentially devastating complication in any critically ill horse, including those recovering from severe hypoxemia.
Laminitis is always a worry.
Always. Muscle damage or nerve damage, neuropathy, can occur from being down for long periods, especially under anesthesia. Secondary infections are a risk, like hospital-acquired pneumonia or infections related to IV catheters or urinary catheters.
Infections, right.
And finally, chronic hypoxemia over time can lead to the development of pulmonary hypertension, high blood pressure in the lung arteries, which puts further strain on the heart.
Wow. That is a comprehensive and pretty sobering list of potential downstream problems. So, okay, we have taken a really deep dive today into the world of equine hypoxemia.
We certainly have.
We've explored its precise definition, that crucial difference from hypoxia, the 5 core mechanisms behind it: hypoventilation, VQ mismatch, shunt, diffusion impairment, low FiO2.
Yep, covered those.
We've gone through the long list of specific conditions, both respiratory and systemic, that can cause it, and the risk factors involved. And then how veterinarians diagnose it, from the gold standard ABG, understanding CO2 and the A gradient, to imaging and other tools.
Right, the whole diagnostic approach.
And finally, the multifaceted treatments, from emergency oxygen and ventilation to targeting the specific cause and the critical follow-up care.
It's a complex area, no doubt, but understanding these details, I think, really offers a unique window into the incredible physiological challenges these magnificent animals can face.
It really does. It highlights that intricate dance of oxygen, blood, tissue function, everything needed just for life, let alone for peak athletic performance.
Well said.
So what does this all mean for you, listening? Well, who knew, right?
Yeah.
That something seemingly simple, like maybe a horse lying down for too long under anesthesia, could kick off such a complicated cascade of oxygen problems.
So you add a lactasis link is huge.
For me, I think the biggest revelation or reminder today is just how incredibly interconnected all the body systems are when it comes to something as fundamental as oxygen.
Absolutely.
It really drives home that treating just one symptom, like low oxygen, is rarely enough. You absolutely had to dig deep, find that true root cause, and that is the real deep dive.
Couldn't agree more. Finding and treating the primary problem is everything.
So here's a final thought to leave you with. Consider how our growing, in-depth understanding of equine respiratory physiology and critical care doesn't just save individual lives, vital as that is. It also constantly pushes the boundaries of veterinary medicine itself, revealing more about the incredible resilience, but also the interconnectedness of biological systems in all species, including ourselves. Something to ponder.